Hi, Chris Montero here at EMS Today 2015, and we're coming to you on JEMS.com and talking to you about several issues around MIH-IA with Dr. Paul Hinchey, Andy Hoffmeister, and Laura, I forgot your last name?
Slocum.
Laura Slocum. So, Dr. Paul Hinchey, sir.
Yes, Chris.
Where are you from? What do you do?
So I'm the medical director for Austin and Travis County, and I'm also the medical director for the National Association of EMTs.
Very cool. So what program are you doing in Austin, Travis County?
So we started out with easing into a community health we call a community health paramedic program, and the goal of the program was to try and find populations in our community that needed help that can't be met with the traditional model of EMS.
Okay.
And so we really sort of started moving through different populations, seeing what resources were out there for us and who we could help and how we could connect patients with their needed resources. And that's how we came across the MCOT program.
Okay. And Andy, are you the extraordinaire behind the program?
Just been given the opportunity to try new things and try and evolve forward with our program. But I'm originally from Southern California. Grew up in Ventura County. Started with Austin EMS back in 2001, and 2009 was given the opportunity to move forward with this program, and was given the idea of this is what we want to try and accomplish. These are the things we want to try and do. It's a growing concept, not really sure where to start, but these are some ideas and these are some objectives we want to try and meet. So that's kind of where we started, and it's kind of evolved working with MCOT, and where we go from here, who knows.
Cool. And Laura, what do you do then?
So I'm the practice manager of the Mobile Crisis Outreach Team, which is the MCOT we keep referring to.
Okay.
And so an MCOT model are licensed clinicians that respond to psychiatric crises in the community.
Wow.
So everything we do is in the community, whether that's in a person's residence, a parking lot, a park, wherever EMS is at when they respond to the call. So we provide the initial psychiatric crisis assessment with the goal of keeping them in the least restrictive environment that's still clinically appropriate for the case. And then we have the capacity to follow up for up to 90 days with that individual for crisis relapse prevention, so they're not calling 911 the next day and the next day after that.
Wow. And so how have you seen, working with the paramedics, how's that evolved, and what do you see as some of the early successes?
So it's evolved, an easy way to say it's evolved has been in numbers. We started out kind of purposefully bottlenecking the referrals coming from CHIP alone to have a proof of concept, as Dr. Hinchey is fond of saying, that it would actually work. And so they had 3 CHIP staff look at cases that were coded as appropriate low priority psychiatric calls that they could dispatch us through the 911 call center to come out and meet them on scene. Since it started with CHIP, it rolled out to captains after that, then commanders, and then in December they rolled it out to the entire department to have the ability to dispatch us. So it's evolved in which of their personnel can actually make referrals to us. In terms of really refining the referral criteria, we haven't made many changes since we started.
Wow.
The medical criteria that Dr. Hinchey collaborated with our medical director on seems to be a really good fit thus far. We have a really good diversion rate, which we operationally define as any disposition other than landing in an emergency room after the assessment. And that has stayed steady at right under 80%, a diversion rate.
That's huge. So how does that make the medics feel to have a resource like that?
I think it's a big boost in confidence, and giving them the opportunity to feel as if they can actually get the patient to the right resource. For so many years, I think a lot of folks, they knew that taking to the emergency room or getting them into touch with that resource wasn't going to get them get the patient what they needed. But knowing that MCOT's there now and is an opportunity to get a patient linked up with the right resource at the right time, and a resource that actually is probably not available in a lot of emergency rooms, and the higher level of care for a psychiatric crisis. So I think for a lot of paramedics, it's very satisfying that they're given the opportunity to identify something and try and get the right resource to the patient right then and there, as opposed to kind of starting at the emergency room and then kind of hoping that they end up in the right place later on.
Very cool.
It's also our goal that when we go out on calls, within the first 5 to 10 minutes, we clear the ambulance. And if they think it's appropriate to leave, they can do that and become available for medical emergency calls, which they are expert at.
But so the therapists and counselors that work for you, they don't ever feel like, oh my God, I want them there so they can give drugs in case the person's psychotic, or do you is that like a first rule out? They're not psychotic, you can leave.
Oh, no. Psychosis is a really big reason for referral that we get from EMS. So everyone on the MCOT team specializes in severe mental illness and psychiatric crisis. So we have a pretty high threshold for what we are comfortable with. We're not maverick about it, and we're not going to say, hey, we don't feel safe, but go ahead and go.
Right.
But the vast majority of the time, we feel very safe. Otherwise, they wouldn't have dispatched us to come out on scene. And we also really focus on safety planning as a de-escalation tool as opposed to medication. With psychosis, that might be one where you're looking more at medication, but we have a prescriber that we can bring out on scene in those instances that it's appropriate.
Well, but that's all that's in our tool belt, though. I mean, that's all we can whip out, and that. But now you guys have another resource.
Chemical
That's
restraints.
great. Yeah, exactly.
One thing that's really helped us realize is that the MCOT model has been around for a long time, and they have an MCOT team that takes referrals from the community where EMS and police are never even involved. So they're very comfortable. They know how to assess and go through and evaluate whether the patient's really a threat to themselves or other, and if they're personally in danger. So these services take place outside of EMS and outside public safety every day, and they know and work with these patients in the home. So this is just the first opportunity that I'm aware of in our area where we've linked up the two services. And so for us, we're used to seeing the worst of the worst and having that concern, but they've been working with patients in the community for years without ever having police or EMS involved. So
very cool. Doc, what do you see from your side? Practicing and then being a part of the paramedic team, what do you see as benefits, and how do you see this progressing?
So I hope this is similar to what our colleagues are seeing all across the country that are dabbling in or have started community health programs, mobile integrated health, whatever the moniker is you want to call it. We found MCOT through working through different populations. We found a resource in MCOT, and they were almost perfectly suited. They're essentially an EMS version of mobile healthcare, mental health care, and so it was a perfect natural fit. And this has been sort of proof of concept. The idea of experimenting with Andy's group with the community health paramedic program, building the feasibility, making the connections, and then being able to expand it to the point where it's become mainstream for our providers. And what that does is we can maximize the patient touch, the number of contacts we have with patients, and get them routed to the right place. From a political standpoint, our average wait time to place a mental health patient in our emergency departments is 14 hours.
Wow.
So if you can see a normal throughput time about 3 hours per patient, you're looking at a huge opportunity cost in all these patients that were formerly boarding in the emergency department.
Right. And for no other reason than to find them a bed.
They just need a home. Yeah. And so we go out, and 80% of the time these guys touch them, they're going someplace else. It's better for them, better for the emergency department, and it's better for the system.
That's great. Oh my gosh, it's so easy. It's brilliant. I mean, that's what you want. That's what you want. And I mean, I know we're dealing with this in our own area. We're trying to get our mental health providers to understand what we're trying to do, and so we're all kind of like walking around the edge of this. Like, how do we make this work? They will be seeing this episode, by the way, because I think for me, what's important is that you guys have made it. You've made it seamless. You made it easy, and you were willing to do it and willing to try.
Sure.
Right.
Yeah, we've been really grateful for the opportunity because, as Andy said, we've been doing this for years without public safety officers at the vast majority of it, or first responders. So for us, it's been business as usual, except that we have faster response times because they necessitate that, and the client does. But we're still providing the same services, so it was really a leap of faith on their parts and a willingness to try something new. And we're very grateful for that. They've been amazing partners.
Right on. Well, thank you guys very much.
Great. Thank you, Chris.
Doc, what's next in the community health world for you guys? What are you thinking about?
So we're trying to work through. Basically, it's moving to new populations. So who can we find next and managed. We have a couple different programs working with patient navigation, basically getting them to the right patient, right resource, in the right amount of time, the common mantra. Hypertension, diabetes, heart failure are our big ticket items. We took a run at heart failure once before and had a bit of a catastrophic collapse because of internal hospital politics. But Andy's persistent, and we
Nice. You've got to be, right? You have.
Yeah, you just kind of keep going,
bang.
and eventually the squeaky wheel gets the oil.
we're gonna show them what's good for them. And so, but it's a great opportunity, and it empowers the crews to be able to do, like as Andy was saying before, it empowers the crews to do something other than just pick them up and go to the hospital. We've all seen the revolving door.
Right.
We know it doesn't work. This is a great option for
Well,
us.
and I think what you guys are doing is exactly what other programs have done. They'll do one thing and they're like, wow, that was a really big success. Let's do something else, and that to me is the value that we're starting to provide. And I really applaud that. Great job, guys. I mean,
Thank you.
that's really that shows what true integrated health can be, what true integration in communities can be, and how it can really affect our patients. So I really appreciate that.
Thank you.
Thank you, guys.
Thank you.
It was a great job.
Thank you.
Thank you guys for watching this episode on JEMS.com, and you can always find more information on the ProMed Network. And thanks for watching. I'm Chris Montera here at EMS Today 2015.